Now, as you rightly said, first of all, the cirrhosis, we do not know how severe the condition is. This is a case scenario that has been given in the question paper. One of the paper will all have only case scenarios and their management. So when you have a theory question like that, I always advise the students to classify the challenges in that case or case scenario. So here you have a patient who has been diagnosed to have a comorbidity like cirrhosis liver, and he has suffered a fracture of both bones forearm. So he requires a surgery for that. So here the challenge is he is suffering from cirrhosis, established diagnosis. Second is he is having a limb surgery, upper limb surgery. It is not a very major one. So these are the two challenges. And so you have to evaluate the cirrhotic lesion in this patient, how severe it is. So for that you have to know what are all the pathological changes that happen in the patient in the various systems and how badly he is affected. And then once you make a diagnosis of that with all the investigations, always you must do the risk stratification. That is the second point that will be written in your answer. So based on that, of course, CPT scoring, what are the classifications you will have? How do you use
Sir,
this?
it is classified into class A, B, and C, sir.
Class A, B, and C. Very good. What is the significance of that?
Sir, it has a mortality predictor around 10% for class A and 30% for class B and around 80% for class C, sir.
So as the class becomes more and more severe, A is the least affected. Even though patient is called cirrhosis, it belongs to A, is as good as A is a 2 patient. Okay? Whereas if it is class 3 or C, he is a very severely affected patient. He may have severe portal hypertension, he may have arthritis, he may have a chances of aspiration, failure, hepatorenal syndrome, jaundice, everything may be there. So this stratification is very, very important. And based on that, you are supposed to select the anesthesia and manage that patient. And being an upper limb procedure, the first choice will always be a regional technique in the form of an upper limb block. It can be a supraclavicular, infraclavicular, axillary, whatever block you want to know, you can perform well. That can be selected. And of course, there are advantages over the general anesthesia if you use regional, and that should be the first option, provided the contraindications for that are, what are the contraindications for regional anesthesia in this patient?
Coagulopathy, sir.
But is that the only one? When you write a theory exam, you have to give all the contraindications. So do you think coagulopathy is the only contraindication? Supposing patient says, I don't want regional. Can you still force him and give him a regional?
No, sir. If the patient refuses or if there is any
Patient
local side,
refusal is always the first contraindication. The patient says, I
yes,
don't want regional, I don't want to be awake during the procedure, you can't force him. Second thing, always, whenever there is a plan for a regional, you look at the skin and the site of injection. If there is any infection there, you cannot give regional.
yes.
Third is coagulopathy, which is a part of the spectrum of disease. Will he have only a bleeding tendency, or there is a possibility he can develop thrombosis also?
Yes, sir. He can also develop thrombosis, sir.
Why? What is the reason?
Sir, since both the clotting factors, also the anti-clotting, both the factors are being produced in the liver. So we may not be sure which level is going to be high. So at some point of time, the patient might be at the risk of DVT. Also, same time the patient might be at the risk of bleeding.
So liver produces both procoagulant and anticoagulant factors. Okay, and that balance has to be maintained. If that is tilted towards more suppression of anticoagulant, then you will have a procoagulant dominance, and we can develop thrombosis also. Okay? Right. So these are the points that you have to keep in your mind. So I'll just give you some of the important facts. What you have to remember is the extrahepatic effects of cirrhosis in the liver. This will be useful to you even in your Viva exam also. So you classify them according to the system. The cardiovascular changes, respiratory, gastrointestinal, renal, CNS, endocrine, and enterological. So these are all the things which you all commonly know. Cardiovascular, it produces hyperdynamic circulation with high cardiac output because of low SVR, and relative hypovolemia secondary to systemic and splanchnic vasodilatation. Cirrhotic cardiomyopathy. The patient may have diastolic dysfunction, prolonged QT interval, and blunted contractile response to stress. So all these things are the cardiovascular changes, for which, of course, we will do the investigation like echo and yes, frank cardiac failure. What is the marker for cardiac failure?
NT-proBNP.
NT-proBNP. Very good, fantastic. And respiratory, if he has severe ascites, that will cause mechanical compression of lung, and the hepatomegaly can lead to impaired lung movement, basal atelectasis, alveolar hyperventilation, decreased FRC, etc. And he may have hepatic hydrothorax. He can have hepatopulmonary syndrome and portopulmonary syndrome. All these things are the respiratory changes. The gastrointestinal tract, mainly portal hypertension, esophageal varices, and spontaneous bacterial peritonitis are all the complications. Renal, it can have acute or chronic renal dysfunction, and hepatorenal syndrome is one of the important things. In central nervous system, hepatic encephalopathy, potentially reversible psychiatric abnormality, and other things. Nutrition, you have malnutrition, muscle wasting, hypoglycemia, hypoalbuminemia, etc. Endocrine, adrenal insufficiency, secondary hyperaldosteronism, and hematology can have coagulopathy, anemia, thrombocytopenia, or hypohydrogenemia. Okay? So these are all the things which you may be asked in the practical exam if you get a cirrhosis liver, and you can just mention these things as a bullet points in your theory answer also if this question is happening. And the changes that happen in the hemostatic balance in chronic liver failure is the procoagulant factors to anticoagulant factor, how they are balanced because both are produced in the liver. And the few risk scoring systems. You said about MELD, NVLA, NALD, NLDNA, CTP, these are all known to all of you. And there are two more new scoring systems or risk stratification system. One is the Mayo risk score, RS. And here they take into consideration the age as well as the alcohol associated or cost of the cirrhosis, and the ASA classification is included. And the newer one, which is called the vocal pen risk scoring system, apart from the one which is taken in CTP and MELD, they take body mass index, platelet count, whether it is a non-alcoholic fatty liver disease, and ASA classification, and the emergency or the elective indication for the surgery. So all these things are taken into account to make the risk stratification more specific with regard to the patients who are coming for surgery. So these two are recent ones which have been included. So you better know them also so that if the examiner asks, you can say that. And what are the preoperative considerations to whether to proceed with the elective surgery or not? There is another guideline given. A preoperative patient with liver disease, if they have acute liver failure or acute liver injury, defer and cancel, consider alternate management. So if both bone fracture can be managed conservatively also with a immobilization. And so if the patient's condition is very serious with the patient is in ALF or early, then defer the surgery. When the CTPA class A or MELD less than, consider proceeding with caution. If the CTP scoring is B, class B and MELD 10 to 1, consider proceeding with caution and after optimization of the patient. Try to correct whatever defect is there as much as possible. And if it is CTPC or MELD more than 15, defer, cancel, consider alternate management in lieu of surgery. So this is the guideline with regard to the severity of liver disease, how to proceed. The earlier one was the risk stratification. This is the guideline for whether to proceed or not to proceed. In between, you can proceed with caution and optimization. These are the four categories of decision making that you can do. And a thorough preoperative assessment, including history, examination, investigation, is mandatory for all patients with liver disease. And all patients should be physiologically optimized by before surgery, and the early involvement of an experienced multidisciplinary team has to be shown to improve outcomes, especially if the patient belongs to a very high risk category of classification. Then it should be a multidisciplinary team with more invasive monitoring and good post-op care ICU facilities all should be available. Now, intraoperative management, always you can discuss that you have to choose between RA versus GA, and for all, whether it is RA or GA, full monitoring as per the guidelines should be present. And the first option for open reduction and internal fixation of forearm both bone fracture is regional block, the form of mini upper limb block that you know. Advantages of RA, it produces complete analgesia and no major hemodynamic changes will happen in this patient. And there is no stress on the liver because you are avoiding polypharmacy, which you will practice with GA. You use several drugs to maintain GA. That is not there. You are using to use only one regional local anesthetic drug. And you can monitor cerebral function intraoperatively because patient may be mildly sedated or fully awake. So you can look for any changes in the cerebral function. And you can prolong the post-op analgesia if you are going to use a catheter technique, so that post-op recovery also will be much easier for the patient. Disadvantages of RA are patient cooperation is very, very essential. So if the patient is very apprehensive and he half-heartedly accepts for the procedure, then you may have problem, because even with a good block, patient may say, I'm feeling here, I'm just having some pain, and I can feel the pulling. All these things may be some for you as well as the patient. And the calculation of the local anesthetic drug should be done very, very correctly, because all the local anesthetics are metabolized only in the liver. Most of the amide local anesthetics are broken down only in the liver. So dosage should be kept to the minimum possible. And chances of direct vascular injection, especially when you give supraclavicular or infraclavicular blocks, you are very close to major blood vessels. So direct injection and local anesthetic systemic toxicity can happen. And lastly, any regional technique has got its own inherent quality of being patchy or inadequate, or sometimes a total failed block also can happen. With regard to the contraindications for regional, patient refusal comes as the foremost, then coagulopathy, then infection at the site of the block. Now, if GA is the only option because patient refuses or some other reason coagulopathy is there and you are not, you don't want to risk giving RA, then conduct of GA, the basic principle is avoid hypoxia, hypercarbia, hypotension, and acidosis. Because hypotension and acidosis will worsen the liver failure, the patient may go in for liver damage at the end of the surgery. So the basic concept is to maintain or avoid these complications. Then induction, the drug of choice will be titrated doses of propofol. And relaxant, as you rightly said, atracurium or ciprofloxacin. And analgesics, fentanyl, remifentanil, or titrated doses of paracetamol, because even paracetamol is metabolized only in the liver. So routine use of paracetamol 1 gram TDS or is not indicated. And the inhalation agent of choice will be desflurane, followed by isoflurane, and lastly sevoflurane can be used. And airway management, you can use second or third generation LMA also. Not necessary that you should always use ET tube. But if patient has especially a large ascites and chances of aspiration are there, only second or third generation LMA should be used, not the regular classic LMA. And reversal with neostigmine titrated doses should be used. These are all the points that you have to keep in mind when answering a question like that.